Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience. Naruvi Hospitals.
Yeah, I can see all the doctors. Let's start. Good morning, everyone. Welcome to today's webinar on prevention of illness, immunizing the elderly, as part of the Healthy India, Happy India series presented by Naruvi Hospitals, Vellore, in association with the Hindu. This 15-part series aims to promote preventive health care through expert discussions. Today's session, the sixth in the series, focuses on immunizing the elderly. In India, childhood immunization is better structured, but elderly immunization remains largely overlooked. As immunity weakens with age, older adults become more vulnerable to infections. Despite the availability of vaccines, awareness and implementation remain challenges. So, we have four esteemed medical experts with us today to shed light on this critical topic. Dr. Kiran Thomas, Senior Consultant Physician and Clinical Epidemiologist, Naruvi Hospitals, Vellore. Dr. Dilip Mathai, Director of Medical Education and Quality Improvement, Naruvi Hospitals, Vellore. Dr. Soumendra Nath Haldar, Assistant Professor, Infectious Diseases and Advanced Microbiology, School of Tropical Medicine, Kolkata. Dr. Vasant Sinakvekar, Infectious Diseases Consultant, HM Reliance and Leelavati Hospital, Mumbai. Each of them will provide key insights into the role of immunization in elderly healthcare. A note before we start, audience are welcome to post your questions in the chat box anytime during the session. We'll address them at the end of the discussion. We kindly request you to refrain from asking questions related to personal diagnosis or individual treatment plans, as those are best discussed in a private consultation with a healthcare professional. We begin with Dr. Kudin Thomas, Senior Consultant Physician and Clinical Epidemiologist at Naruvi Hospitals, Vellore. Dr. Thomas has had a long and accomplished career in medicine and research. He previously served as Professor and Head of the Department of Medicine, Christian Medical College, Vellore, and the Pondicherry Institute of Medical Sciences. His contributions to infectious disease research, epidemiology, and adult immunization programs have been significant. He has played a key role in multiple international projects and on antimicrobial resistance and vaccine surveillance. Today, Dr. Thomas will explain why immunization is important for the elderly and discuss key vaccines that can help prevent serious infections. Dr. Thomas, over to you.
Thank you, Athira. Let me just start my presentation. Full presentation. Okay. Okay. Good morning, everybody. Today I'm going to speak about the immunization of the elderly, which is a forgotten priority as far as healthcare in India. As you see, what I plan to do today is give you a bird's eye view of how it is becoming increasingly ever more important to have the elderly get some kind of immunization and primary prevention strategies to cope with their illness in the future, and also touch upon two important vaccines which I've worked on to understand it further. Everyone knows that all of us are aware that the vaccination for the childhood is very important. These are some pictures of mothers queuing up for their babies for getting routine immunization of tetanus, polio, pertussis, measles, hepatitis B, TB, etc. The coverage in most parts of India, and particularly in states like Tamil Nadu, Kerala, and southern states of India, is very high in range of more than 90%. But when it comes to the elderly, very little is done. People over 60 years of age susceptible to serious infections, yet we are not addressing the issue in a very serious mode as yet. Let me explain what is the kind of problem that we are facing. The elderly are more vulnerable to serious infections. The immune system is less effective as age advances. The tissue regeneration is much slower. Many comorbidities occur at the age advances, like diabetes, cardiac failure, malignancies, which make them more prone for infections. And of course, lifestyle are also problems like smoking and alcoholism are also problems related to adult lifestyle. What happens if we look at our life expectancy at birth? When we got independence in the life expectancy at birth was 30 years at that time. 2025, in most states in India, it is over 70 years. Of course, India is made up of multiple states and they have differences between states, But overall, in many states, the age is that the expectancy has gone more than 70 years. And the result of that is that adult and elderly population is rapidly increasing in our population. And this is an estimate of the elderly population in India in 2025. As you see here, around 140, nearly 140 crores of elderly people, of total population are there in India today. And when you touch upon the above 65 years, at around 2000, it was just 4.5 crores. But today, it has become 2025, it has reached 10 crore. 10 crore of elderly population is the kind of problem that we are facing today. The elderly have double burden of illness. They're not only prone to get infectious diseases, but also non-communicable lifestyle diseases. Though the double burden has to be addressed. Or if you look at many of these hospitals, tertiary care, or even secondary care level hospitals, 80 to 90% of the ICU beds are often occupied by the elderly, which results in poor quality of life for them and very expensive for the family who takes care of them. Preventive strategies are very effective for NCDs, for example, except in risk reduction. But lifestyles are difficult to change. But of course, we require, while focusing on them, but IDs have to be addressed is much more easier. Many infectious disease vaccines, which are easily vaccine preventable, and we should emphasize on getting reduction in this morbidity using the vaccine strategy. But they are extremely poorly utilized, where multiple reasons are there, which requires both supply side and demand side. The supply side, the doctor's mindset that vaccine is not for adults and elderly, but for pediatric age group still remains, because it's not been part of the regular medical curriculum. Poor knowledge about existing vaccines and efficacy still persist. From the demand side, the economics of vaccine production and utilization, you have to spend higher amount of money for a future benefit. That is very difficult to understand for many people. Of course, there is myths associated with vaccination that is associated with immune system overload and autoimmune disease. In summary, what I could say is that as far as importance is concerned, the rapid growth of elderly population in India is in 2025, if it is 10 crores, some estimates in 2050 project it as high as 50 crores. Elderly more vulnerable to disease, and double burden of NCDs and IDs reduce quality of life and increase cost of treatment. And vaccination is one of the most cost-effective way to reduce vaccine-preventable diseases in the elderly. It improves quality of life and reduce cost of care for this elderly. So I think it's very important that we understand that the vaccines is the one strategy which will reduce this burden of infectious diseases in the elderly. Now, I will touch upon two vaccines, which I think there are, Dr. Dilip will touch upon all that vaccines that are available for the elderly population. But to my mind, I think I discuss a little bit more about two important vaccines, pneumococcal vaccination and hepatitis B, in which I have been involved in the past. Pneumo vaccination, approximately about 150 million cases of pneumonia a year globally. About 43 million episodes in India alone, and resulting in around 8 lakhs deaths due to India in India. About 50% of that is occurs in the elderly and 50% in the young. But there is one difference. Most of the severe pneumonia is bacterial, except in the situation of viral epidemics that we just passed through, like COVID, where viral epidemics cause a large amount of burden of mortality due to pneumonia. The single most important agent that causes it is pneumococcal disease. It is a very significant pattern of it. At the very below 2 years also, the incidence is very high, and then it raises again at the age of around 60, 64, it goes up again. This double peaking of the disease is typical of the most common organism causing pneumonia. Very difficult to identify it by routine examination, but even definitive viral study of bacterial studies looking lumbar puncture have shown about 30 to 40% of severe pneumonia is caused by pneumococci. The organism not only causes pneumonia, it is invasive in disease and it produces much severe disease. Pneumonia is somewhere in the middle, but a much larger burden due to otitis media in children and septicemia and meningitis in the adult. And the mortality increases as the invasiveness and severity of the disease occurs. For example, if you look at as the age group advances, in children, the mortality is less than 2%. But in adults, the mortality in 20 to 50 is 30%. Above 65, it's around 40%. And this increases. For example, in meningitis, it is very high as compared to pneumonia, which is around 20%. So the importance of this vaccine, if you can produce, the large trial, capital trial in 2015, which causes community-acquired pneumonia by immunizing with the vaccination, pneumonia immunization trial in adult, found that 45% reduction in non-invasive pneumonia and invasive severe pneumonia reduction up to 75% by using conjugate vaccine in adults. This is a very interesting, in addition to the reduction in mortality, this is an additional the data that you're showing the screening of antimicrobial resistance in a global level. We find here in many parts of the world, India is fortunately only very small level of penicillin resistance for pneumococci as compared to our neighboring country of Sri Lanka, which is coming to around 40% of penicillin resistance. And if you look at globally, a bird's eye view, Sri Lanka is so close to India that it's very easy for this invasive serotypes to cross over and produce infections in our country as well. And what does it result in? Bacterial resistance increases the cost of treatment many times over. And this is the data which shows that when you look at vaccine, the vaccine prevents both the specific serotypes which are involved with high levels of bacterial resistance. So that brings down the cost of treatment significantly. There are a number of organizations which has recommended routine use. In our own country, National Center for Disease Control has also recommended, but World Health Organization, Advisory Committee on Immunization, American Society, Geriatric Society, Canadian Medical Association, all of these agencies have recommended pneumococcal vaccine very strongly for use in the elderly population. The current recommendation, of course, is we have PCV13, which is a conjugate vaccine, which gives you higher levels of protection in the initial, followed by polysaccharide vaccine, which is gives you a higher spectrum of coverage for serotype coverage in the adult. Of course, there are higher PCV20 and PCV21, which give very good effect, but they are much costlier, and it may not be may be easily available in India. So in about hepatitis B, let me touch upon it. Hepatitis B is a global burden is very high, about 1.2 million deaths annually, causing liver cirrhosis and malignancy. The protective efficacy of hepatitis B vaccine ranges between 70 to 80% in developing countries. Currently, it is part of universal vaccination program in India, which is about a few years ago. But however, while it protects the young, we have forgotten the elderly. Majority of the elderly and adult population in India remain unprotected. The population are increasing in size. This is the kind of data we generated from Tamil Nadu, which shows that lifetime expectancy or lifetime contact with hepatitis B is highest and across all age groups, about nearly 30%. It's very cheap vaccine, and 3 doses will give you protection for a very high level of protection is available. Adult vaccination, India has made part of mandatory for childhood vaccination. The Indian manufacturer cost very, very cheap. Currently, the coverage of elderly is very poor. Again, the issue is about, as I touched upon, the supply side and demand side issues are there. But The long-term benefits over short-term gains are not easily perceived by the population. And anti-vaccine lobby is also a reality who are spreading the myths related to the vaccine and its toxicity. I'll end with the question, have you been vaccinated? Thank you.
Thank you, Doctor. Next, we have Dr. Dilip Matai, Director of Medical Education and Quality Improvement at Naruvi Hospitals, Vellore. Dr. Mehta is a renowned infectious disease specialist with a distinguished career spanning clinical medicine, medical education, and research. He has previously served as a professor and head of medicine at CMC Vellore and later as dean at Apollo Institute of Medical Sciences, Hyderabad. He holds several prestigious positions, including president of the AIDS Society of India, editor of the Journal of Global Infectious Diseases, convener of the FNVID Specialty Board at the National Board of Examinations, and with over 435 research papers and book chapters published and having been a guest speaker at over 300 medical conferences. Dr. Mehta is a leading voice in infectious disease management. In today's session, he'll provide an overview of different vaccines available for adults and guidelines for adult immunization. Please go ahead, Dr. Mehta.
Yeah, thank you, Tira, and good morning to all. Make it full. Yeah. Now, with Dr. Kurian Thomas had made his presentation, so it makes my job a little easier. But my outline of my talk would be some aspects of elderly care, the biology of aging, a little bit on the immunology of vaccination. But my major talk would be on the types of vaccine and the national consensus guidelines as such, and a little bit about vaccine hesitancy among the elderly. Now, immunization is a leapfrog activity. I think it's one of the activities that are, transcends all other activities in saving lives among the older adults. Agreed physical activity is very important. Nutrition and diet, chronic disease management, managing their regular medication, managing their finances, mental health, loneliness are all, very important. But immunization transcends all of these activities. The second part is immunization should be part of a life course approach. The life course approach is, moving from medical intervention to health promotion or illness prevention. This should be the life course approach for most people once they cross the age of 50 or 60. Now, Kurian has already alluded to this, but what I want you to understand is from his data, you will find that in 2050, there will be a great demographic transition. The adults over 65 will exceed children less than 15 years of age. That is an important thing to note because you will find that we are all focusing on this childhood vaccination, which results in the adults living up to 65. And you will find that we have nothing to offer for the adults over 65. Please understand that elderly are at risk population. You've got three aspects to them. Why are they at risk? Comorbidities, immunosenescence, and hospitalizations. Now, the frequency of occurrence of multi-morbid conditions, more than 3, more than 2, more than 1, is there amongst the elderly. We don't see many patients with old age associated death without any comorbidity. My father lived to the age of 98 with no comorbidities. My mother lived till 88 with multiple comorbidities. But what I'm saying, what you will find that the comorbid conditions and multimorbid conditions would continue with them. Secondly, the age-related decline in immune functions. And you will find that when does immunosenescence occur? We have no exact time for the immunosenescence. Is it 50? Is it 45? But by large, we accept that 50, 55 immunosenescence begins to set in. Now, hospitalization, you have seen from Dr. Kurian's data that the hospitalization for VPD would also be high, leading to medical complications. So prioritizing preventive care is important in elderly care. Now, what do we mean by the elderly? Sometimes some people don't like the word elderly. Some people like the word older population, but that's not what I am getting at now. Aging is unavoidable. It is progressive. Yes, there are people who are trying to retard the progression. Brian Johnson, for example, he's on medications and various other activities to retard the progress. Today, we know man's life expectancy is 120 years based upon the longevity of one single person. We cannot control the speed of aging, but maybe people say that, genetic factors are important. Genetic factors are really important for people beyond the age of 85. It is actually lifestyle factors that are important up to the age of 85. So modify your lifestyle up to the age of 45, and after 85, probably it would be genetic factors. With physical fitness, vision, hearing, mobility, all of these decline. Now you can't, maybe you can retard it or maybe you can build it up. But please remember that organs also age. Skin is the classical example. Most body systems have considerable reserve, and disease-free aging is really not possible. So organ function declined by 1% starting at the age of 25. The criteria for age and definition of aging vary. In my field of HIV, we take that 50 years for persons living with HIV is the cutoff point for old age or cutoff point for age. And so we begin immunization early on that. Senescence is the biological definition of aging. There are no biomarkers for senescence. We do not know. We do not know our telomere length to say that we are senescent. So having said this, what is its importance in vaccine, in vaccinology? Immunosenescence, there are functional defects and altered frequency of our innate and adaptive immune cells. I don't want to go into details of this adaptive immune cells. The time immemorial, we know that if an antigen comes into the body or is introduced in the body by vaccination, antibodies are formed and these are protective. And that is how you measure immunogenicity of a vaccine. But more importantly, it is the memory T cells and their cytokine release that perpetuates the immune response. So based on this, we may have to give repeat doses. Based on this, we look at T cell dependent vaccines as being more powerful, but as such, particularly the conjugate vaccines, which Dr. Kurian had alluded to. Now, antibody responses are weaker. There are people who may not respond appropriately, or they may decline faster. We cannot be sure about their long-term protective efficacy and cannot be taken for granted. That is why we go for booster vaccines. Even if we go for booster vaccines, we don't know how frequently we should give it or whether the booster vaccine has an effect. So we believe that it will have an effect. Therefore, improved vaccine strategies, new adjuvants, and new vaccines are therefore needed. Having said this, now, how many vaccines are there out there? I can count for you 30 vaccines as such. Now, we have according to the WHO, we can classify it into these 4 types: live attenuated, inactivated, toxoid, and subunit vaccines. But it's why do I want to classify it like that? Because you will have a better understanding when I show you the next slide. But today we are going to discuss amongst these 30 vaccines, only 7 or 8 of them marked in red. Dr. Kurian had already completed pneumococcal polysaccharide as well as the conjugate vaccine and hepatitis B. And the subsequent speakers would be covering the other vaccines. The types of vaccines, so these 30 vaccines that are out there, some are registered, some are in clinical trials, some have been discontinued. And the reason you should understand as to why we classify them is based on the nature of the pathogen. The pathogen can be either a bacteria or a virus. And then let us say you have the immune response that is required. Then you can combine more than one pathogen. MMR, that is mumps, measles, and rubella can be combined. DTP, diphtheria, tetanus, and acellular pertussis can be combined. Then you got combined 7 vaccine series. So manufacturing is easier, rollout is easier, reactogenicity local is less, cost of manufacture may be less, etc. So if you classify this as basically toxoid vaccine, diphtheria and tetanus, the earliest vaccine, excellent. They are against the toxins produced by this bacteria. Live vaccines mimics natural illness, provides a longer lasting immunity. And today we have got the virion-like particles, mostly HPV vaccine and the herpes zoster vaccine. But they're modified. But they're non-live, they're less potent. Short-term protection requires repeated doses. Okay, and this attenuated, they are made from weakened strains. So they are unlabeled, so you cannot transmit diseases through this, and neither can you. But for live vaccines like oral polio vaccine and maybe the live influenza vaccine are contraindicated in people who have got an immunocompromised state as such. Now, basically, it's just vaccinology has exploded with the development of the subunit vaccines. They've got more purification steps, contain less protein parts, less reactogenic. You've got generations of inactivated plus influenza vaccine. So they're supposed to be more immunogenic. So you've got the HIV, the pneumococcal pertussis, that is the cellular pertussis. You've got the recombinant protein hepatitis B. You've got the split virion vaccine, and you've got the virion-like particles, that is HPV. Then your DNA vaccine, which you have heard of during corona, mRNA vaccine useful in cancers, and then you have the vector base. So having stated this, so we've got about 30 vaccines and the types of vaccine are different. And we use, how many do we really use in the elderly? The definition of the elderly being anybody above the age of 45 or anybody, even adolescent and adults and the truly elderly. So if you look at it, okay, several guidelines have been issued. It's for the children, it is perfect. Even in India, the IAP guidelines are excellent. In adolescents, they have got this. So now there are country-specific guidelines as well. Now, when we wrote this book in 2015, since then the whole scenario has changed, and now we have come to an Indian consensus, making sure that most of the societies participated in this discussion, and this was published in 2025 January. Now, they have suggested that there are 22 vaccines available. Okay. Now, for all adults, I have just highlighted pneumococcal and herpes zoster. We will be having a discussion on herpes zoster shingles later. Annual influenza, Dr. Vasant will be discussing this as well. We've already heard about hepatitis B virus. Dr. Vasant will be discussing about varicella. Now, Tdap, that is tetanus and diphtheria and acellular pertussis, is recommended 1 dose every 10 years. Now, whenever anybody comes for wound management or road traffic accident, young or the old, we give them tetanus. And then if animal bites, we give them rabies. Then MMR, actually, it is for the college-going students, where the institutions request that their rubella status be known, or even young females request that their rubella status known. If it's not known, we give them a dose of MMR. Hepatitis A vaccine, A virus vaccine, we believe that most of us have had hepatitis A, but those who have had a liver disease or for those who are likely to consume alcohol, etc., people recommend hepatitis A. It is mostly recommended for travelers also who come to a country like India, where hepatitis A virus is prevalent. Okay. Now, there are at-risk adult population with immunocompromised states, chronic HIV, cardiac disease, pulmonary, metabolic disease, end-stage renal failure, liver disease, hematological multiple myeloma, based on increased risk if they get severe outcomes in this special population. Residents of nursing homes, we don't have many nursing homes, but now senior living complexes are coming up. Do they require? At-risk adult women, more than 19 years or 21 years during each pregnancy gets a Tdap. And they're also protected against hepatitis B if they have not had the preliminary series of infection. Quadrivalent meningococcal vaccine, you will hear about it with Dr. Soumendra, who will be speaking on this. We don't use RSV. In the US, they're using for bronchiolitis. And we don't use HPV in India, even for the HIV population and in the MSM, HPV vaccine, which prevents cervical cancer, very well known, recommended by the WHO as well, is still not being used. We have mandatory travel vaccines, film for the pilgrims, military, university students, those who participated in the Kumbh Mela. So now the IPL season is opening up. Do we need to give them vaccines? Those are questions. We have no guidance and not applicable for HIV, rotavirus, polio, BCG as such. In the pandemic mode, that's a different story altogether. Because we've got the mpox kept in reserve, the Ebola kept in reserve, the plague kept in reserve, the Japanese bee and the anthrax, and they are only for specific geographical areas. So, having said this, now we go on to the vaccine hesitancy as such. We've shown you the national population. Now, everybody asks this question, do they work? Do I really have to answer this question? Because right from the discovery of smallpox, which has been eradicated, and then rabies, which has been prevented but not really been eliminated as such, and you've seen it in the pandemic mode of this coronavirus, maybe people might debate this, and we know that it works. Now, prevention of herpes zoster difficult to study, but it may reduce the risk of stroke, transient ischemic attack, myocardial infarction. WHO strategy has shown that we can eliminate cervical cancer. So in different ways, it has been shown that really works. Immunogenicity profile needs to be studied. The efficacy needs to be studied. The efficiency needs to be understood. Public health education are required to improving the uptake of immunization among the elderly. Now, in one of the most extensive market research and IPOS study, people believe that there are better ways to protect than other vaccination. I don't know what it is, but let's see. Maybe the naturopathy, etc. I'm not challenging those. 50, about half of them believe that direct exposure would boost better. Yes, but do you want to take a chance that direct exposure could give you a morbid situation? Now, 50% of aging adults depend on vaccine. Yeah, you have to be dependent on something to protect yourself. Fearing needles at this age, we take our children. The needles today, it's almost painless. Now, everybody has the presumption that I don't need it because I'm not at risk of falling ill. So we need a primary care given patient education to enhance awareness. Awareness to action and awareness to uptake. Now, I was the dean of the medical college. Now, I had the privilege. Now, most important is access and availability. So, answer to Dr. Kurian's question, am I vaccinated? This slide will say, yes, I am vaccinated. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Mathai. Now let's hear from Dr. Somendra Nadhalda, Assistant Professor, Department of Infectious Diseases and Advanced Microbiology, School of Tropical Medicine, Kolkata. Dr. Somendra Nadhalda is a specialist in infectious diseases, microbiology, and immunization programs dedicated to improving vaccine access and disease surveillance in India. He holds a degree in medicine and a specialization in tropical medicine from the School of Tropical Medicine, Kolkata, along with further training in infectious diseases from the All India Institute of Medical Sciences in New Delhi. With 10 national and 1 international publication, he currently works as a consultant in infectious diseases at Fortis Hospital, Anandapur, Kolkata. He is also a member of the State Technical Resource Group for the Triple Elimination Program. In today's session, Dr. Halda will discuss vaccine for food and waterborne diseases. Over to you, Doctor.
Thank you. Is my slides visible? Is my slides visible?
Yes,
go ahead. Yes.
Yeah. So, yeah, thank you. Thank you, Professor Mathai, sir, for giving me the opportunity. So I think my previous speaker, Professor Mathai, sir, and Professor Thomas, sir, they have described everything very well. It's very difficult for me to speak anything after that. Still, as requested me, so I will see something regarding the vaccination. Especially, I will mention the vaccines which is transmitted through fecal-oral route, the diseases, and meningococcal vaccine. So, meningococcal vaccine, as in just previous talk, Dr. Mathai sir already told that it is mandatory for the pilgrims, specifically the Hajj pilgrims, they should take the vaccine. So few words regarding the vaccine. Basically, the serotypes causing the disease is ACYW135. So some preliminary words regarding the vaccine is, when you are taking a vaccine, don't think that you were 100% protected from the vaccine and there is zero chance of getting the disease. Yes, the risk benefit ratio is definitely for taking the vaccine. And whenever you are taking the vaccine, like I'm giving one example of pneumococcal vaccine. So when you are taking PPSB 23, so you will be getting protection from those serotypes which is covered in the vaccine. So please think of this specific serotype, specific immunity, which you will be getting after taking the vaccine. Regarding the polysaccharide versus conjugate vaccine, yes, polysaccharide vaccine only activates the T cells, B cells. It only produces the antibody without activating the T cells. Conjugate vaccine, it carries a carrier protein which helps to activate the T cells. There are two specific terms, class switching and memory B cell production, which happens with the conjugate vaccine. So always the conjugate vaccine is better than the polysaccharide vaccine. Quadrivalent vaccines are available for the meningococcal diseases. Indications are apart from the aging, as today we are discussing about the elderly population. In India, now the medical science is progressing very rapidly. So we are now doing the transplantations in all parts of the India. So previously it was limited to certain centers of India. Plus in all over India now transplantation is happening. And so the relevance of the vaccine is much more for this subgroup of population apart from elderly population, like a patient who is getting hematopoietic stem cell transplant, a patient who is having some solid organ transplant like liver transplantation, kidney transplantation, a patient who is getting some monoclonal antibodies like rituximab, and we are using the monoclonal antibodies to a large number of populations who is having some skin disease, who is having some autoinflammatory syndromes. So the vaccine is very much relevant nowadays for the elderly population and for the other subgroup of populations also. So for the meningococcal vaccine, they should take 2 doses at an interval of 8 weeks. And for the travel in the countries with the hyperendemic or endemic meningococcal disease, they should take the vaccine single dose. So it is very important before giving any vaccine, you should know whom you are giving the vaccine, what is the ideal time for giving the vaccine, what is the dosing schedule, what should be the route of the vaccine, and the interval between the two successive doses of the vaccine. So these things are very important and always you should know about that. So during the outbreak, the meningococcal vaccine is needed for the healthcare personnel, the lab workers, usually single dose is needed. Please think of one thing, whenever you are giving meningococcal vaccine, don't give it simultaneously with the pneumococcal vaccine. There are two brands of meningococcal vaccine. One is Menectra, one is Menveo. So if you are giving Menectra, don't give Menectra with the Prevnar 13 because there are some interactions which may reduce the efficacy of the meningococcal vaccine. So as Professor Mathai sir already told about the hepatitis A vaccine, hepatitis A vaccine is specifically in the patient who are having advanced liver disease, like a patient who is having chronic hepatitis B or chronic hepatitis C infection or cirrhosis due to other reasons, he must get hepatitis A vaccine, because if the patient acquires hepatitis A on top of a cirrhotic liver, the disease course is fatal. And so always the benefit which the patient will be getting by the hepatitis vaccine is more rather than developing a fulminant hepatitis A infection. Hepatitis A vaccine is now combined with the other vaccines also, like hepatitis B vaccine, the name is Twinrix. It may be combined with the typhoid vaccines, Vietnam or Vivaxim. And there is one thing, the Biovac A is available in India, which is a live attenuated hepatitis A vaccine. Usually you should give 2 doses, a 0 and second dose is 6 to 12 months. But if you are giving with the hepatitis B vaccine, then the dosing schedule will be 0, 1 and 6 months. The indications are traveling to the countries with high hepatitis A rates, chronic liver disease, as I have previously mentioned, IDUs and unvaccinated individual in outbreak settings. This is important. In outbreak settings, you should give it to the other peoples also. One thing is that if you give hepatitis A vaccine earlier, like when a patient is having acute fulminant liver disease or a decompensated liver disease, then the vaccine efficacy is to some extent poor in comparison to the patient who is having, like a patient who is having childbug C, the vaccine efficacy is poor in comparison to a patient who is having childbug A or a patient having a normal liver. HIV positive patients, they should get hepatitis A vaccine in advance, and it's better if you give the vaccine when the CD4 count is more than 300, because at that point of time B cells and T cell functions are better than in a severely immunocompromised state, like when the CD4 count is less than 200. So few words about the typhoid vaccine. The disease is caused by the Salmonella typhi, and it does not give any protection against paratyphi. It's very clear. And it is indicated for travelers with the risk of exposure to hepatitis A. This is very important. Polysaccharide versus conjugate vaccine is basically, I have previously described also. Polysaccharide versus conjugate vaccine. Conjugate vaccine is to some extent better than the polysaccharide vaccine. My previous line, it should not be hepatitis A. Indicated for the travelers with the risk of exposure to the enteric fever. It's not hepatitis A. Sorry for the typing error. So fourth line is oral typhoid vaccine. I think it is not validated for use in India. It's available in abroad. In India, we are getting conjugated vaccine TCV, 0.5 ml IM dose, and it should not be administered with 72 hours of antibiotic therapy, because there is some interactions if you concomitantly use antibiotics with the vaccine. The vaccine efficacy is approximately 50 to 60%, and it lasts over 2 to 3 years. So if you are staying in an area where continuous protection is needed against Salmonella typhi, you should take the vaccine every 3 years. So regarding cholera vaccine, this is not very relevant nowadays, because previously the quality of sanitation was not very good, and frequently we usually see some outbreaks of cholera vaccine. But now it is indicated for a special group of population like refugee, like healthcare worker in endemic areas, then other camps and urban areas with the unsanitary conditions. This is very important. If the sanitation, it is not possible to improve the sanitary system in a particular area, and where there is history of cholera outbreak, in that particular area, they are beneficial after getting the vaccine. Nowadays, the Vaxcora is a live attenuated oral vaccine. It is recommended, it is used in USA. It is recommended in USA also. In India, we are having good quality vaccines, like we are having Shankol oral vaccine. 2 doses is given. 2 doses is given at an interval of at least 2 weeks. So previously what happened, the vaccines, they usually gives protection against serover 01. But there are in India, particularly in the West Bengal and Bihar and other parts, there is documented cholera outbreak by 0139 strain. So what is now needed, the Shankol conjugate vaccine, now it includes the both serotype, both 01 and 0139. That is beneficial, that it gives protection against both the serotypes. So strain specific protection is very important. So I think now few words about, as we are running one adult immunization clinic at School of Tropical Medicine, Kolkata, funded by the government of West Bengal. So the vaccines are available here. And what you should do, what we do, that like when we assess a patient, and we first decide whether he is eligible for getting the vaccine or not. After that, we give the vaccine by trained nurses. After that 1 hour, we examine the patient for any adverse reactions with what he is developing or not. After that, we send back the patient to his home, and we do a phone call after 4 days and after 7 days, how he is doing with the vaccine, like whether he is developing any kind of adverse reactions earlier or later, like that. Vaccines, most of the times vaccines, the adverse reactions is very, very less. Till date, only we have seen one patient who is having some sort of seizure after taking the pneumococcal vaccine, but subsequently we examined the patient, we have taken the history. The patient was not taking the anti-epileptic drugs for last 7 days. So that was probably the reason. So the vaccines are very safe. And regarding the cost, so the now, like sir previously mentioned, Shingrix, the cost of Shingrix is not very low. So we should ask the companies to reduce the cost of the vaccine, so that it may be the common people of India, most of them are poor, they can afford the vaccine. Number 3, most important issue, the insurance companies are not covering the vaccines. So there should be some discussions with the insurance companies also, for so that the vaccines can be included in the insurance companies. And the last thing, when you are discharging a patient, you should keep a gap of like 2 to 4 weeks, because when a patient is suffering from an infectious disease, the B cell, T cells are not stable. There is maybe cytokine storm after getting the infection. So wait for at least 4 to 6 weeks. Keep the B cell and T cell stable. After that, you should give the vaccine. Thank you. Thank you, sir. Thank you all.
Thank you, Doctor. Finally, we welcome Dr. Vasanthi Nagwekar, infectious disease consultant at HN Reliance in Lilavati Hospital, Mumbai. Dr. Nagwekar is a leading expert in infectious diseases and vaccine policy in India. He holds several prominent roles, including Fellow of the Infectious Disease Society of America, General Secretary of the Clinical Infectious Diseases Society of India, Scientific Committee member at NIV Pune, Advisory Board member for Infectious Diseases at MUHS. With over 28 national and international research papers and contributions to multiple medical textbooks, Dr. Nagwekar has been instrumental in shaping India's infectious disease strategies. Today, he'll discuss some vital vaccines for the elderly, including influenza and shingles. Dr. Vasant, over to you.
Hello, can you see my slide, Athena?
Yes, sir.
Thank you so much. At the outset, I would like to thank Dr. Dilip Mathai and Naruvi Hospital and Hindu for giving me this opportunity. And it's a pleasure speaking to all of you. So I'll be covering specifically on influenza and herpes zoster, and touch upon varicella, that is chickenpox vaccine, just to have no confusion on this. So influenza, as we see that one of the most common infectious disease, influenza is a respiratory virus that, despite the availability of vaccines and effective antiviral medicine, exerts a substantial toll on global morbidity and mortality every year. It is highly contagious, airborne disease that occurs in seasonal epidemics. The US CDC estimates that seasonal influenza are responsible for an average of more than 20,000 deaths annually. Influenza causes a great loss of work holidays, human suffering, and mortality. Mortality is highest in infants and the elderly population. Seasonal flu is often clinically mild, recognized by a constellation of symptoms including fever, cough, sore throat, and classified as influenza-like illness in absence of other cause of other than influenza. More severe influenza infections can occur and further classified as severe acute respiratory distress syndrome. Pandemics occur when a novel influenza virus enters into the human population and is capable of a rapid spread. In April 2009, a novel strain H1N1 jumped from swine into the humans, and I think my previous speaker said that, and infected over 200 million people globally, resulting in the first influenza pandemic in 21st century. Points to note is that, very important, a person is infectious 24 hours before he develops fever. That means those people who are staying with the person who has developed influenza are already been exposed 24 hours before the person has developed fever. So that's very, very important in influenza. So infectious period is 24 hours before and last at least 48 to 8 hours, at least 24 to 48 hours till the effervescence of the fever. That is usually 48 to 72 hours. The first sign of influenza could be high-grade fever. The temperature gradually declines, but fever may be present up to a week. Other symptoms include chills, anorexia, generalized frontal headache, and systemic complaints. So, what are the diagnostics tests for influenza-like illness? We have the antigen test, which is not very accurate. We have the RT-PCR, which is almost more than 95% accurate. We have the gene expert, which is very accurate, and film array, which is the respiratory biofile, but that's very, very expensive, almost costing anywhere from 12,000 to 15,000, which covers a lot of other viruses and atypical bacterial organisms as well. So these are the, so I would say a gene expert or a RT-PCR would take around 8 hours. Gene expert can give you an answer within 2 hours. Film array can give you an answer within 2 hours. Antigen test, again, I said not very, if it is positive, yes, it is sensitive, but I mean, it is specific, but may not be very sensitive. Whereas RT-PCR, gene expert, film array are sensitive and specific tests, which will give an accurate results. So need for influenza vaccination in patients with comorbidities. Individuals with comorbidities have a significantly higher risk, higher death rate, pneumonia, hospital admission. I'll come to another slide which has a more specific for the elderly population and establishing the need for influenza vaccination. I think this has been covered well with Dilip Patai sir, so I'll not go into this, but this is important. Vaccination in adults more than 65 years of age. A study conducted in adults hospitalized with laboratory confirmed influenza during the 13-14 influenza season in United States demonstrated that influenza vaccination in adults more than 65 years of age resulted in 61% reduction in hospital deaths, 37% reduction in ICU admissions, shorter ICU length of stay, shorter hospital length of stay. So vaccination in adults more than 65 years of age provided significant protection against in-hospital death and ICU admission and significantly resulted in shorter ICU and hospital lengths of stay. This is another slide which talks about the dark, the black one is the for the population who are 85 years and plus. So if you see over a period of 2012, 13, 14, and then 15, the more the age, the more the risk of you developing influenza-like illness and hospitalization. So this comes from the flu survey net, age-related differences in hospitalization rates, clinical presentation, outcomes, and among older adults hospitalized with influenza. You can see the aging more than 65 plus has definitely over a period of time, year by year, it's causing more high risk for hospitalization and ICU stay. Influenza vaccination in adults more than 65 years of age or more. This study found that influenza vaccination reduces the risk of recurrent cardiovascular events, hospital deaths, and direct medical costs. So know your influenza vaccine, which one to be taken. The influenza vaccine is always, influenza virus has two components, that the hemagglutinin, two antigens, and the neuraminidase. So it is always a combination of how it goes, whether it's H1N1 or it is H1, H2, N3 or H3, N2, depends upon which antigen combines with the hemagglutinin combines with the neuraminidase. So if you see this, this is the way how it goes. So the H antigen, if it combines with 1N1, it is H1N1. If it's H3, the third H3 combining with N2, which like we all over India, we had outbreaks about H1N1 and H3N2. In fact, H3N2 was N2 was much more than H1N1. And now we have slight concern about there is a outbreak of H5N1 in Delhi and another 9 states, what I read. But that is more for bird flu. But over a period of time, we have to be just keeping a watch that it can be transmitted to humans, those who are handling the poultry, and it can be transmitted sometimes to the mammals as well. So which vaccine should Indian population should be taking? There are two types of influenza vaccine which are manufactured. One is the Northern Hemisphere vaccine, which is manufactured every September. And there is a Southern Hemisphere vaccine, which is manufactured every April. So which is more relevant to us? What is more relevant to India is the Southern Hemisphere vaccine, which comes in April. So I think it is already manufactured and it will be available in from the April month to be taken. Now, every time, like the 2025 Southern Hemisphere vaccine will be different from the 2024 Southern Hemisphere vaccine. So last year's vaccine and this year's vaccine, there will be a difference because it depends upon what are the circulating viruses. I'll come to the next two slides, how you find out which vaccine should be taken. But suppose somebody has not taken a Southern Hemisphere vaccine and he comes in November and says, Doctor, I forgot to take my vaccine shot in April. Now it's November and Southern Hemisphere vaccine is not available. The answer is whatever is available at that juncture, you should be taking the vaccine. It doesn't matter. You can re-vaccinate in April and then continue every April. So the time frame is what is available at that juncture. You should take it because that would prevent you from that. So if you see the 24 Northern Hemisphere vaccine and 2025 Southern Hemisphere vaccine, the influenza A1 is Thailand, and this has been replaced by the Croatia, which was a circulating virus in the previous year. And this is how the need for the latest influenza vaccine is the latest strain which had been circulating in the previous season. So continuous change of circulating influenza viruses lead to a change of influenza vaccine strains recommended annually, and that's why we require to take every yearly vaccine because every yearly the strains may be different. So as per WHO, the most recent WHO influenza virus vaccine recommendation should be used independent of the hemisphere in which country it is situated. As I said, if somebody comes in November, in India, doesn't matter whether it's Northern Hemisphere, what is available at that juncture should be taken. And the vaccine has around 50 to 60% protection. Just one mention, which is not available in India, but should be coming to India as it's available in our neighboring country, Thailand. This is a Fluzone high dose seasonal flu vaccine, and it is more recommended for people who are 65 years of age and more adults. And what you can see from this slide is that compared to the standard dose, the Fluzone high dose has 4 times the amount of the amount of the virus particle in that, whether it's a split or the particle size, it is 4 times higher. And compared to that, if you use a standard dose, what is available in India, and if you use Fluzone high dose, there's a 24% reduction in fewer influenza illnesses, and again 51% fewer influenza cases come if you use a high dose. Also, if you see that 27.8% reduction against pneumonia and hospitalization versus the standard dose which is available in India, similarly 12.8% against cardiovascular related hospitalizations compared to the standard dose. But this high dose flu vaccine is not available, but this is just for your information. It is available in US and it is available in our neighboring country, Bangkok. So if you see the difference again, your regular 15 micrograms of standard dose gives you protection around 50 to 60%, whereas a high dose vaccine gives you protection from anywhere from 80 to 95%. So recommendations for influenza vaccines are from various societies. If you see the Indian Academy of Pediatrics, and you'll see a lot of international societies which strongly recommend about the influenza vaccine, especially for people who are having about 65 years of age, and those people who are having severe comorbidities, transplant population, and also in the second trimester during pregnancy, also it is indicated. Coming to herpes zoster, this is a classical herpes zoster which affects one specific dermatome and it does not cross the border. So what about herpes zoster vaccines? So that herpes zoster affects almost approximately 1 in 3 persons in their lifetime, and the risk of herpes zoster increases with increasing age. The most common debilitating complications of herpes zoster to why should we take the vaccine is the chronic neuropathic pain and the post-herpetic neuralgia which develops. There are two types of vaccines. One is a live vaccine which is manufactured by Merck, Zostavac, which was available earlier in India, now no more available. It was a live vaccine. When we have the present one which is available in India is the Shingrix, which is a recombinant zoster vaccine, and it is much more effective in preventing herpes zoster than the Zostavac, which was manufactured by Merck. And if you see, though, who would get the herpes zoster? Herpes zoster you will get only people who have suffered from chickenpox, and 99% of the population, more than 95%, have clinically or subclinically suffered from herpes from chickenpox. And what happens is once you develop chickenpox, the virus remains dormant in the dermatome, and it keeps with more stimulation. It keeps building the immunity, but over a period of time, as your aging goes on, the immunity decreases, and then the virus replication in that dermatome goes higher, and that produces the herpes zoster. So if you see in all over the country, as your age advances, you can see nicely the arrow above 65, your chances of getting herpes zoster, that is 1 in 3, would be much higher, and more, I think, with the specific, more with partly immunocompromised state, that is diabetes, asthma, patients on steroids, patients on immunosuppressants, they are high risk for developing herpes zoster. So if you see, there are two vaccines which I spoke about, Zostavac and Shingrix. The Shingrix, if you see the overall efficacy, is 90, against herpes zoster is 97.2%, whereas in preventing post-herpetic neuralgia, it is 91.2%. So far, what do we know? So far, we know that it protects at least minimum 10 years after the vaccine has been given. The protection is approximately 10 years. So if you see this, again, the slide between the two different vaccines, you will still see that the Shingrix, which is available presently, gives a much stronger, broader immune response, and it remains for a longer time, for almost 10 years, compared to the Zostavac, which is no more available in India now, which was not giving such a broad. It was just giving 50% protection, whereas this is giving more than 90% protection. So indications for vaccination for herpes zoster would be all immunocompetent persons aged more than 50 years. Australian government says there are two different thoughts about 65 and 50, but standard ACIP and CDC says that more than 50 years of age. HIV, anybody who's having a stable CD4 count of more than 200 at least 6 months apart should be taken, can be considered. And those people above 18 years of age only who are immunocompromised and who are at increased risk of herpes zoster and related complication should be considered for herpes. Very important, the next sentence is persons who have previously received, suppose somebody had taken zoster live vaccine in the past, should be revaccinated with a full 2 doses of series of Shingrix, which is a recombinant herpes zoster vaccine which is available in India. Zoster vaccination is indicated even if the previous episode of shingles, suppose somebody had already developed herpes zoster, still he requires to prevent further episodes of herpes zoster, he requires to be vaccinated 6 months or 1 year later. Zoster disease at less than 50 years of age in immunocompetent person is not a zoster vaccine indication. It is only about 50 years of age. So no need of doing titers to check whether I've suffered from chickenpox or not in the past. I think straight away you can take above 50 years of age, 2 doses of Shingrix, around 4 to 8 weeks apart. That is what, and not more than 6 months later. The recommendation is above 50 years of age and those people who may be having comorbid conditions. So 2 dose series to be taken at a gap of 2 to 6 months interval. So I think there is a difference between the chickenpox vaccine and the Shingrix, that is herpes zoster vaccine. Shingrix is not indicated for prevention of primary varicella infection, and chickenpox vaccine is not indicated to prevent prevention of Shingrix, that is prevention of herpes zoster. But chickenpox vaccine is a live vaccine, whereas the Shingrix, which is available in India, is a recombinant killed vaccine. So difference is chickenpox vaccine is usually given at 2 doses at 4 to 8 weeks apart in adults. It's very, very important that adults who have not suffered from chickenpox, please check your titers. If you're negative, then you get vaccinated with chickenpox, because chickenpox in adults is very severe and can cause morbidity and mortality. Especially, I think those young ladies who are not suffered from chickenpox and getting pregnant or going to become pregnant, at least 4 weeks before they get pregnancy or before marriage, they should check their IgG-VZV titers, because chickenpox, if you develop or during the pregnancy, or if you come in contact with a person who has got chickenpox, then to prevention in pregnancy is really nightmare. So it's very, very important that you see that you are safe through your pregnancy, for especially two important vaccines, that is chickenpox and rubella. So that's what is very, very important. So I think I'll stop here, and thank you so much for listening, and I'll be happy to answer all your questions.
Thank you, Dr. Vasant. I think now we can move on to the question and answer session. If you have any questions, please drop them in the chat box if you haven't already. Let's go through them one by one. I'll try to combine similar ones. So we have questions asking if there are any single vaccination that covers multiple preventions, like if there are different vaccines be given simultaneously, example hepatitis, influenza.
Yeah.
They're asking, is there a single vaccine for everything?
Yeah.
Okay, I think Dilip will answer.
So there is a hexim. So there is a one vaccine which covers 6 different variant. That is, it covers hip, it covers hepatitis B, it covers so it covers 6 different. So that is the only one, but there is no vaccine which covers everything. It's a kill vaccine.
Yes, sir. Also, these vaccines that we talked about, are these only for the elderly? That's another question.
This question has been addressed partly by Dilip earlier, because the vaccines have been generated for the biological age. Then, of course, as the immune system drops in efficiency, the biological age is the issue. There are people who are younger but then are extremely fragile. Then, of course, the indication would be that you can give it at the younger age group. Of course, indications for vaccination is increasing for diabetic people in the younger age group, for people with cardiac failure, people with malignancy. They all become indicated as the probability of infection goes higher, the indication for vaccine becomes. So it is not as if it's only given for that age group, but certainly biological age and chronological age matches to somewhat in most majority of the people. Therefore, the recommendation are based on chronological age. But a clinician can choose when to give based on the idea of his biological age.
Also, if there is another question asking if how doctors decide which vaccines an elderly patient needs based on their medical history.
Can you repeat it?
Yeah. How doctors decide what vaccine to go for based on their medical history in elderly.
The vaccines that we have talked about, the Dilip has talked about the 8 to 10 vaccines, which are recommended as part of the guideline, routinely given for everybody over the age of 65. There are many other vaccines which can be given as indicated. Some for what people who are traveling to high-risk area, some for before pregnancy, some maybe for as a ring vaccination, some post-exposure. But there are vaccines because as age advances, there is immunological suppression, and therefore the 8 to 10 vaccines are indicated routinely to be given for all people above the age of 65. Yes, Dilip, can you want to continue?
Yeah, but
Shall we move on to another next
Yeah.
question, or you?
One thing is now, if you have a healthy person more than 60 years of age, routinely giving PCV 13, yes, followed by PPSV 23 after 1 year or 6 months, fine. That is one vaccine that I will recommend. Second is the recombinant shingles above the age of 65, 2 doses, one now and one after 6 months, negotiable as such. So you've got 1+1 +1+1, that is 4 doses to cover 2 diseases. Third one is certainly I would give tetanus toxoid to anybody above the age of any new, even if they've had their primary series of injections for during routine wound management and once in 10 years or after animal bites, rabies. I also add it for snake bites as well. So that will be 5. 6 is the annual influenza. So that will give annually. Now, as next one is hepatitis B. Now, hepatitis B, 4 doses or 3 doses, rapid or slow, that's all a decision that you can make. Certainly, because because hepatitis B in our country, the prevalence is high, 5% is the rate now for hepatitis B. It is also sexually transmitted. The third part of it is needle stick is only for hospital healthcare workers. But remember that we get a lot of intramuscular injections from practitioners who might not be using sterile techniques. So I would recommend hepatitis B. I am a street food eater. I eat food from the streets. Don't tell my wife that, but I eat food from the street. So I have taken typhoid vaccine. I've taken, but I have not taken the next dose. I've taken that PCV, that is a conjugate vaccine. I didn't take the live one, but I believe more in the conjugate vaccine. Maybe it has a 60% effectiveness, but I'm very selective about the food. So that. Now, regarding diphtheria and acellular pertussis, let me be very frank with you. I have not taken. I had once handled a patient with diphtheria. At that time, I took diphtheria, tetanus, diphtheria, and pertussis. Now, acellular pertussis is available. I have not seen pertussis in the classical sense, Cronibacterium, diphtheria, and the whooping cough as such. But there are viral, but we don't have any vaccines for that. So if somebody wants, you can take acellular pertussis. HPV. I'm beyond the age of getting HPV, but a 16-year-old or a 26-year-old male or female requires an HPV vaccine because there is no way, at least females, to prevent the occurrence of cervical cancer. Not an infectious disease, but if you get this HPV, which is an infectious organism, at least you will not cause the transformation of the cells into a malignant stage. So HPV for women, I will strongly recommend let's from 14 before sexual maturity or whatever you want to call it as, from 14 till 26, because you don't know who your lifelong partner is going to be. So it's much better for them to take a HPV vaccine. It is extendable for 45. We give it in MSM, male having sex with male, for them so that they don't get HPV. At least you prevent venereal warts, anogenital cancers as such. Beyond that, I do not have any great recommendation for the vaccine. Of course, we don't talk about it. Cholera, I don't take. Rabies. I'm a runner. I have pre-exposure prophylaxis for rabies. I've taken short doses of pre-exposure vaccine. The reason being that I do not know if I should get bitten by a dog or during my running. I have taken 3 doses. Now, do I recommend it? Well, if you go to some place where anti-rabies globulin is not available, then you take your chance. But the number of stray dogs in our country have increased. I'm not blaming. Have the dogs being immunized? Yes and no, I have no evidence. So therefore, a runner like me, I take pre-exposure prophylaxis. I recommend it for those who are in the emergency services because they would be seeing patients with rabies, dumb rabies, and that is my vaccination schedule for people in the adult age group.
Thank you, sir. We are running out of time, but let's take one more because I think more than two people have asked the same question. If there are a full list of vaccination released by any national programs in India for people above age of 60, if there are any full list provided, is so you're on mute, Dr. Kudin, you're on mute. Dr. Kudin, unmute yourself.
The point, national program has not funded adult immunization program for obvious reasons. Childhood immunization, efficiency of the program is calculated by the cost effectiveness or the quality life prolonged, quality adjusted life prolonged. At the age of 70, to get quality adjusted life prolongation is no longer the objective. The objective becomes reducing the cost and burden of disease, quality of life for people. And then it will be equivalent to, it's a curative care issue. So as a national prevention, it has not come up to the higher priority as childhood immunization. But that doesn't mean it is an importance. As you progress, as I said, when you have a population of 50 crore Indian of elderly population, will it become a priority? I do not know. That we have to think. Currently, it is no longer, it's not a funded program.
Thank you, Doctor. I think that brings an end to the rest of the remaining questions would be answered by mail, so no worries. This brings to the end of today's webinar. Huge thanks to our panelists for their time and expertise. To summarize, all the adults are at risk of infections, making vaccination is essential for their health. And so raising awareness and encouraging proactive vaccination is vital in India. And some of the recommended vaccinations for all adults have been mentioned by the doctors throughout the webinar. This was the 6th webinar in the Healthy India, Happy India series. Stay tuned for more expert-led discussions on important healthcare topics in the coming weeks. Thank you all for joining. Have a great day.
Thank you very much.
Thank you.
Thank you. Thank you, sir.
Thank you, sir.
But there are some questions there which we have not answered in the chat box.
Yes.
I said
There are. Yeah.
send it to us. We can do it.
Priya,
Thank you so much.
should I be taking note?
1.5 hours. Okay, brilliant. It's 1.5 hours. Because there were no disruptions. Everybody spoke well.
Yes.
Everybody covered everything. You're not taking.